good day, and good evening to our internet audience across the globe. I am Brent Ponce, Chair of Research at the Houston Foundation and Chair of AO Sports. I'll be the moderator for this evening's seminar. This webinar we are honored to partner with the Boston Shoulder Institute, and we have 3 shoulder luminaries to teach the symposium on the scapula demystified, what the practicing sports doc needs to know. Before we begin, we have a few administrative details. What I'll do at the beginning of each presentation is introduce our distinguished faculty. We're going to start off tonight with Joaquin Sanchez-Sotolo, followed by Dr. Warner, followed by Bassem El-Hassan. And thinking about the conflicts of interest, there are none that are relevant to tonight's presentation. AO North America is an independent, nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. As the priority is education, AO North America does not endorse nor to promote the use of any product or service of commercial entities. Any equipment used in this course is for demonstration and teaching purposes with the intent to enhance the learning experience. A little bit of background and the purpose for this presentation tonight. Lack of exposure and training leads to limited understanding of scapular-related disorders. This webinar is for practicing sports surgeons and surgeons who treat shoulder pain. The evaluation of the scapula and associated scapular disorders will be discussed. Improved understanding and proper assessment of the scapula in patients with shoulder pain is foundational to determine accurate diagnosis and providing proper treatment. Learning objectives is to describe how to evaluate the scapula and associated scapular disorders, identify and recognize differences between common shoulder palsies, describe the treatment options for scapulothoracic abnormal motion. Here's tonight's agenda. And getting things started will be Joaquin Sanchez-Sotolo, followed by Dr. Warner, followed by Dr. El-Hassan. And we'll have some time at the end, if it permits, with questions. And we'll seek to end right at 9. I want to take a minute just to encourage folks. We have a shoulder tendon transfer course that is being placed on in Boston with the Shoulder Institute. Dr. El-Hassan, Warner, and Sanchez-Sotolo are the chairs and co-chairs. It's a 3-day course. We'll hear more about it as we go through this presentation. And just want to thank everyone for their participation this evening. And with that, Joaquin, I'll introduce you while you're getting your slides up. So Dr. Joaquin Sanchez-Sotolo was born in Madrid, Spain, where he went to medical school, received his PhD, and did his residency before he came to the Mayo Clinic and did 2 fellowships. He has over 150 publications and over 50 book chapters, and has twice won the Teacher of the Year award at Mayo. He will be speaking tonight on scapular evaluation. Where do I start? Joaquin?
Thank you, Brent. Welcome, everyone. This is such a nice activity tonight because I would argue, like Dr. Ponce was saying, that most of you that are sports surgeons under the teaching leadership of the AO Foundation may have less exposure to the scapula. And tonight, our goal is to, number one, tell you what we think people should know as they start to dive into scapular problems at different levels. And number two, invite you to the wonderful course that Dr. El-Hassan has organized with the very limited help of Dr. Warner and myself and Dr. Ponce as director. So many people wonder, when I really want to learn about the scapula, where do I start? And the whole topic of this presentation today and the 2 that will follow is to demystify the scapula. And I really like this CT scan because it shows 2 things. Number one, when you think about the scapula, you must look at the patient from posteriorly. So you can see how the CT scan shows the scapula, the clavicle, the chest wall, the humerus from the back. Number two, it shows all these different structures that are potentially all implicated in scapular pathology. And some of our partners that haven't really learned much about the scapula for years, they continue to think that the scapula is the black box of the shoulder. And interestingly, I didn't know what the black box is actually an orange box. So the key tonight is to understand how can I work with my history, physical examination, maybe imaging studies and understanding of the scapula to place all these pieces of the puzzle together so that they can finally make a diagnosis and help all these patients that oftentimes are told, look, we don't know what's going on. There is no solution, do more physical therapy. But I think after tonight, hopefully, you can get it right many times. It's important to realize that there are many conditions that are not related to the periscapular muscles that will present as a scapulothoracic disorder, or like Dr. Hassan has defined, STAM conditions or abnormal scapulothoracic motion. So clavicle malunion, clavicle non-union, SC joint dislocation, AC joint dislocation, fractures and malunions of the scapula. Some very rare, but occasionally present scapulothoracic tumors like a osteochondroma of the scapula or maybe an elastofibroma in the scapula as well. Chest wall abnormalities, brachial plexus injuries. There are many of them that will present as scapular problems, although tonight we're going to concentrate mostly on the periscapular muscles. But look at this patient that was sent to me for possible dysfunction of the scapula on her left side. This is her active motion. And to be honest, when I examined her, I thought maybe she has a trapezius palsy, because as I asked her to shrug the shoulders, you can see how on the right, she's perfectly able to do so, not so much on the left, very limited. Now, the caveat is that this patient had had a pretty bad car accident and had a clavicle fracture that healed with substantial malunion. And what we did for her is, in addition to getting an EMG to make sure that she didn't have a trapezius palsy, is a corrective osteotomy of the clavicle. And 2 weeks after the clavicle was back to normal, she was already able to elevate her arm symmetrically. So as you see patients with scapular problems, don't forget that it could be the clavicle, the AC joint, the SC joint, the chest wall, and so on. Having said that, tonight we're going to concentrate on the muscles that control the scapula, and I will divide my presentation in some very brief anatomic considerations. We'll talk about how I scan for scapular dyskinesis, a few dedicated maneuvers that probably Dr. Warner and Dr. El Hassan will cover in more detail. What is the value of the scapular assistant test, and is there any role of imaging and EMG with nerve conduction studies? So as we all know, the anatomy of the periscapular region can become complicated very quickly, but you can simplify the thinking about two groups of muscles, the posterior muscles and the anterior muscles. And the posterior muscles are in two layers, basically. The trapezius is one more superficial, bigger muscle, and then right behind or underneath, you have the levator scapulae and then the rhomboids, minor and major. Whereas anteriorly, we typically concentrate on issues that relate to the serratus anterior or the pec minor. And one way to think about it is to think that the scapula has all these little bony prominences because they can function for the muscles are joysticks. So the red sphere represents where the serratus anterior drives the scapula into protraction, for example. The yellow sphere, which is the coracoid, is the attachment site of the pec minor. So if the pec minor contracts, there will be anterior tilt and, of course, shortening of that space that can compromise the brachial plexus and adjacent vessels. The trapezius will concentrate on controlling the scapula from the whole spine in a very coordinated fashion, and the rhomboids are straight medial. So this is a very, very quick animation of the functions of different portions of the scapular muscles. The middle trapezius and the rhomboids will do what we call retraction, or some people call scapular adduction. Whereas for protraction, the main muscle is the serratus. The pec minor can assist a little bit. Then we have other function, which we call elevation, or what people call shoulder shrug, which in the deeper layer is by the levator and the rhomboids, but mostly by the upper trapezius. Whereas depression, or getting the shoulder blade inferiorly, is by the lower trapezius, and of course the latissimus dorsi and the pec minor contribute as well to some extent. When a patient or a human elevates the arm, it requires the combined coordinated effort of the upper trapezius, the lower trapezius, and the serratus. And this is what makes arm elevation so beautiful. Whereas for downward rotation, it's more a combination of the levator, rhomboids, and pec minor. And then remember that if the pec minor gets shortened or contracted, it will lead to an anterior tilt. Whereas the serratus and trapezius will lead to posterior tilt. which means that if there is a paralysis of either or both, there will be a static anterior tilt, and that's why some patients with serratus or trapezius palsy will be already diagnosed with chronic subacromial impingement. How do you scan for very quickly when you have a busy sports medicine clinic and you really want to make sure that you don't miss these problems for scapular pathology? I like to tell my residents and fellows, just think about making an onion ring in the air. So if you have a patient that you have with the shirt off and looking from the back, you can ask the patient to elevate the arms 5 to 10 times, and very quickly you can pick up if there is any minor abnormality, like in this patient, a very, very minor abnormal scapular motion on the left. This is a more profound right-sided long thoracic nerve pulse, so you can really pick this up very quickly by just having the patients get the hands up and down. So this is where you start. Now you can also use some specific maneuvers for the muscles that are most commonly affected. For the serratus anterior, which is the muscle that boxers use to box, or swimmers, classically, people talked about the push-up on the wall, and I learned from Dr. El-Hassan that this doesn't really help you. So what I try to do is replicate the function of the muscle with the boxer punch test, where you can have the patient replicating a boxing maneuver of punching, and then you can try to that way test scapular protection. Or you can do the test that Dr. Hassan has described as resistive flexion test that will accentuate the deformity when the serratus anterior is unable to keep the scapula on the chest wall. So there is a patient with a right-sided serratus anterior palsy. You can see how, as we scan this patient, it's very clear that the right side has abnormal scapulothoracic motion. Her trapezius is perfect. You can see how she has retraction of the shoulders. And if I place my hand on the pelvis on the left and I push forward, the ability for the patient to resist anterior translation is symmetric. On the contrary, on the left normal side, as the patient tries to flex the shoulder, you can see how the scapula remains opposed, whereas on the right pathologic side, there is prominence of the scapula. So a very, very good test, and not so much the push-up test. Trapezius palsy, completely different. The key here is that when the trapezius is compromised, it's like the upper extremity falls away from the chest. So if you use a marking pen and mark where is the spine of the patient, you will see how the medial edge of the scapula is really lateral compared to the opposite side. And I really like this scapular flip test, where the patient does resisted external rotation, that will accentuate the deformity of trapezius palsy. You can see here how in the resting position, the scapula is sideways in this patient with a right-sided trapezius palsy. And then they typically have difficulty more in abduction, sometimes in flexion. And as we test their strength, if they do a shrug, even if they have a very powerful levator and rhomboids, you can see how on the right is very easy to break her as compared to the left. Scapular retraction will be weakened. So on the left, normal size, I can easily resist my push, whereas on the right, I can easily break her. And then her deformity will be accentuated with resisted external rotation, the so-called scapular flip sign. What's the value of the scapular assistance test? In patients where the serratus anterior is compromised, either because there is a true nerve injury or avulsion, or because there is functional disability of the serratus, patients will be able to all of a sudden raise the hand up in the air much more easily if they are helped by the physician. And the way that Dr. Kibler described this is by using the forearm to support the medial aspect of the scapula and the hand to grab on the acromion. But Dr. Hassan and Warner has taught me to use your hands in front of the back of the patient in the chest and see if that will allow them to elevate the arm more easily. So this is the Kibler way to perform the scapular assistance test. This is the Boston way, where you have a hand in the front, one in the back. You have to make sure that females are okay with your hand position, of course, and then you can see how they can more easily elevate, because you are basically with your left hand, in this case, compensating for the poor function of the serratus, either because it's truly paralyzed or because it has become somehow dysfunctional. Many argue that images and EMG have no value for periscapular assessment. I actually disagree. I like to get these studies for two reasons. If you get them correctly done, they help. and they also can have some medical legal implications. And the key is that if you order a shoulder MRI, which is common, of course, in the practice of sports shoulder surgeons, you will miss out the boat. You need to order a chest MRI that will show the trapezius, the serratus, the rhomboids, the pec minor, and so on. If you're thinking more about a bone deformity, so for example, a scapular malunion, some type of rib deformity, a osteochondroma, a CT scan may be better. Now, EMG can be useful provided the technician knows how to do it. Think about this. These muscles are flat for the most part. If they are injured, they become atrophic, so thinner. It's very easy for the EMG technician to place the needle in the wrong structure and have a false negative EMG. Ultrasound is useful in two situations, in my opinion, to do injections in the subserratus bursa for patients with painful crepitus, pec minor in pec minor syndrome, suprascapular nerve, but also if a patient has a iatrogenic injury to the spinal accessory nerve, and ultrasound can give some hint depending on timing, or if a nerve repair may be of value. Look at this beautiful MRI obtained acutely after an early onset serratus anterior palsy secondary to a long thoracic nerve irritation because of Parsonage Turner syndrome. You can easily see the increased signal change in all three planes of this serratus anterior compared to the other muscles. So in summary, I think understanding prescapular anatomy and function is very important to facilitate examination of the scapula. I think as you start to get your feet wet as a sports medicine surgeon, remember to scan for scapular dyskinesis and learn just a few maneuvers that will very quickly allow you to examine the scapula in 3 to 5 minutes. And the value of the scapular assistance test mostly to unmask the weakness of the serratus anterior. And as I said, very quickly, you can scan patients for abnormal scapulothoracic motion, check the upper trapezius, check the middle trapezius and the rhomboids, check the serratus, do the scapular resistance test, and you can really document very quickly. It's not complicated to do a quick exam of the scapula for most of our patients. If you're interested in learning more, I just published a paper in 2024 that reviews the whole presentation I gave you tonight. It is in the Techniques of Hand Surgery 2024. And of course, please come to the course that Dr. Hassan has organized with the help of Dr. Warner and myself, because if you like the scapula and the rotator cuff, I guarantee you will love it. And it has a lot of cadaver dissection that is very unique with torsos and other activities that you cannot really get anywhere else. So thank you for your attention tonight. Thank you also to the AO Foundation and to Dr. Ponce for organizing this webinar. And I'm looking forward to meeting everyone in Boston, November 14 to 16, 2024.
Thank you, Joaquin. That was outstanding. I don't see any specific questions at this time. So if there are questions, just want to encourage the audience to send the questions in through the chat. And what we can do is we can correlate all those questions and save them till the end, or we can give them after each presentation. So feel free to ask during the presentation, and we can ask the questions specifically afterwards. Let's go on to the next presentation. Dr. J.P. Warner is co-chief of the Mass General Shoulder Service and has been my mentor since residency and fellowship. In 2012, he was the ASES president. He is also the founder and past president of the New England Shoulder and Elbow Society and is the founder of the Codman Shoulder Society. He has authored over 300 peer-reviewed publications, more than 200 book chapters, 5 textbooks on shoulder surgery. He is a multiple-time Near Award winner and is a graduate of Harvard Business School. And tonight he'll be sharing on 2 conditions not to be missed: trapezius and serratus palsy. Dr. Warner, the floor is yours.
Thank you, Brent. Let me just open my presentation and share it here and put it on presentation mode. So I'm going to talk to you today really as a introduction to what follows, in particular BASM. And this is sort of like the BB before BASM. And after he talks, you'll get the AB after BASM. But everything is based on history, and it's important you understand the errors that have been made from a historical perspective in understanding these problems. And because I'm the oldest one in this webinar, I have a perspective on history. Just a word on Boston Shoulder Institute. Boston Shoulder Institute was an outgrowth of my experience at Harvard Business School, which is a patient educational portal And on that portal is a lot of information to explain to patients exactly what the problem is, the treatments can be. It's not updated to the after BASM part. I have to get BASM to do that, but it's very helpful to have patients understand what you're talking about with visuals. And Joaquin's presentation was wonderful in terms of the animation. You've already heard about our course and what our purpose is for that course. Now, I have a number of conflicts of interest. I'm not going to talk about any products here. I have a lot of startup companies. They're also not relevant to anything here. So this is, for lack of a better term, my experience in tendon transfer and really recognition of these problems over 34 years. Because I started to think about this about 2 years into my practice. Let me kind of run through things a bit. I was told to give you some learning objectives. Well, most important in this presentation is how to recognize the problem. And Joaquin gave you information about that, but let me give you some real tangible examples of errors made by sports medicine docs and other shoulder specialty trained individuals. And then set you up for understanding newer procedures and treatments for this problem. Now, if we go back to 1998, who here can identify Bassem El-Hassan in this picture? You probably wouldn't be surprised in the historical content here to figure out that it's a guy with this instrument here. I wonder, in 1998, was Bassem thinking about the scapula? I'm not sure. Probably he had some ideas about it. Now, if we look back at really our source for history, being Google, and we'll also correlate that to PubMed, if you ask the question, who first described tendon transfers or wing scapula, you get about a little over 1 million results. And 3 people that stand out are Robert Leffert, who was the head of the upper extremity rehab service at Mass General in the 1980s when I was a resident, Melvin Post at Rush, I'll talk about him in a moment, and then, of course, Ben Kibler, these again before Bassem. And if you Googled way back when wing scapula, you got about 329. I'm sorry, if you look at PubMed, you got about 329 results. And tendon transfer for winging, 25 results. And then along came Bassem, and now if you look up wing scapula and put his name there, you get almost 8,000 results. So you can kind of see the impact of building on history here, and we'll go over this a little bit. Now, if I look at scapular winging in 2024 in PubMed, 385 results, many of which are Bassem's articles, and you can see the growth of publications from 1978 to 2024. These are, of course, peer-reviewed publications. And again, Google, scapular winging, 333 results in 2023, scapular winging treatment, 134,000. Interesting that there are more articles, there's more hits for treatment than there is for, just the diagnosis. That's relevant. Now, Mel Post was a former president of the American Shoulder Elbow Surgeons. He passed in 2002. He's a very nice man. He was the first surgeon to really identify wing scapula, at least that term, as he described it in the literature. And as I'll show you in a moment, his approach was to do a pec major transfer using iliotibial band. And it was in 1993 that I traveled to Chicago, having referred him one of my patients with what looked to me like scapular winging, that's what we called it at the time, in order that I could watch him do his operation. This patient had a confirmed EMG for a wing scapula. There's a work-related injury too. This was his article in 1995 showing how he did this. This is not a minimal procedure. I mean, he harvested the iliotibial band, and one of the complications were seromas and herniations of the thigh muscles after doing this. And he rolled this up, kind of to look like a tendon, and used it to lengthen the pec major, which he didn't feel could reach all the way to the scapula. And he made this S-shaped incision, took the entire pectoralis major, and then wove this iliotibial band through the pec major, kind of like a pulvertaft weave, and then fixed it into the inferior border of the scapula like this. And this is one of his patients from his published article, which clearly shows significant improvement compared to before and after, as you see B and C there. Now, not long thereafter, Gary Perlmutter, who was a fellow with Robert Leffert at Mass General, reviewed Dr. Leffert's experience doing the same kind of an operation to treat so-called paralysis of the serratus anterior. And then, of course, Ben Kibler came along and published in the AAOS his diagnosis of scapular dyskinesis, it was actually Bob Leffert who coined the term scapulothoracic dyskinesis, which I'm sure Dr. Elasan will put in context for the way he thinks about things with STAM, or scapulothoracic abnormal motion. Now, Columbia got into the game too, and with Lou Biliani and his students, Bill Levine and others, talked about his experience with pec major transfer, and these are some photos from their article in Clinical Orthopedics Related Research in 2008. And this was a small number of patients, 11 cases, average 6 years after symptoms began before their treatment. 2 were idiopathic, 6 were trauma-related, and 1 was after an instability surgery. That's important. Keep that in mind because I'm going to show you why that's relevant. And then here's another example of a so-called wing scapula, same year, where they looked at the so-called Eden-Lang procedure. 6 patients, 5 years after the injury, so longer delay, longer recognition. 3 cases were due to iatrogenic injury, usually a lymph node biopsy, and 3 cases came from traumatic injury, and this was the operation they did. Again, not really what we know works now, and in fact, I'll show you my experience. So how common is this? If you look at the PubMed and you look for articles about this, if these are some of these articles. So serratus anterior with positive EMG, 15 of 7,000 EMGs, or 0.2%, were positive. Here's another one, 1 case in 38,500, and then 3 cases in 12,000 cases. So, 3 positive EMGs in 12,000 cases. So EMG, as Dr. Elasan may mention to you, is not the gold standard for deciding about why it is that someone has STAM. And he may comment on it. Many more articles more recently, most of these with Dr. Elasan involved, and even Dr. Elasan attached his name to scapular dyskinesia, even though STAM is now what he uses. And flexion resistance test he'll probably talk about, and these other articles, again, which emphasize this. Now, let me show you some real cases. This is a case I treated pre-BASM, and this was an individual who came to me after 6 failed instability surgeries performed by a fellowship-trained shoulder surgeon. Now, if you look at this X-ray, the humeral head is subluxated inferiorly, but the deltoid is normal. There's no axillary nerve problem. So why could this happen? These are the operations that were performed. And, what do you think is going on here? Well, this is her exam. And if you ask patients if the first doctor examined them with the shirt off from the back, usually the answer is no if they can remember. So many individuals won't examine the patient from the front or the back, and it's essential to look at the scapular mechanics as well as the glenohumeral mechanics, or you'll make the mistakes that came my way. And so as you'll see in a moment, when the scapula doesn't work, all sorts of problems happen. And this will be so-called STAM that Dr. Elasan will talk about. Now, here's a similar patient who had a failed posterior instability, and you can see there's a difference between the right and the left side. So what happens? And I think Joaquin showed this very nicely. When you have scapular dysfunction and the scapula doesn't normally move, it doesn't move the coracochromial arch appropriately, and you can get impingement symptoms, so-called non-outlet impingement, which actually Dr. Neer talked about in his book in 1990. You can get AC joint-related pain. You can get glenoid malpositioning that results in instability. You can get pain over the scapula medially, and you can get aching in your neck. All things that can lead surgeons to make the wrong diagnosis. Now, you already saw the difference between STAM with serratus dysfunction and trapezius, and this is just an illustration of that from one of our articles. And here's an X-ray that shows what happens when you have dysfunction of the trapezius. You can see on the one side, the left side, lateral rotation of the scapula, which is important to form a platform underneath the humeral head, and failure of the scapula to rotate laterally, which results in uncovering of the humeral head and actually increases the vector of force tangential to the joint line that can lead to instability, and certainly a variety of manifestations, clinical symptoms that are really not the first domino. The first domino is the scapula. Again, limited flexion with winging, wall push-ups, we've already heard, are not ideal. The so-called scapular compression test was something that I described, 20 years ago, based on what I learned from Robert Leffert. And I think others have called it different names, but I think Joaquin alluded to it. Now, what I found, and it may or may not be true, Bassem can comment on this, was that in my early experience, individuals with trapezius palsy were identified later than scapular ringing associated with serratus, and many of them seem to tolerate it better than serratus palsy. I don't know if that's true, but this is a patient I saw who elected no surgical treatment. That's why the numbers may be so small. Now, back to my patient. Here's the before and here's the after. What happened? Well, her 7th operation, which I did, was a tendon transfer, in this case, a pec major transfer, and it allowed the scapula to position more appropriately so the humeral head would now remain centered. This completely eliminated her instability symptoms. And I've seen a number of patients, as you'll see in a moment, who had iatrogenic problems from the surgeries for the wrong diagnoses that led to more problems after I treated, or additional problems after I treated the so-called stam that was missed. Well, this is from our original paper. I used, at the time, I used hamstring tendons because I trained in sports medicine. It was easy to harvest hamstring tendons. And I used that in the way Post had used iliotibial band. And here's a black and white picture of how we did it. We made 2 incisions. The incisions got smaller over time. This was published with Ron Navarro, who at the time was my fellow in Pittsburgh in 1998. And what we concluded was recognition of scapular winging may be difficult and potential errors in treatment can result. Such treatment errors may cause morbidity for the patient. And so we reported on 8 patients with 17 failed surgeries, almost all of which were performed by fellowship-trained sports medicine physicians or shoulder fellowship physicians. And these were the initial diagnoses that were, of course, not the correct ones, and the prior surgeries, many of which resulted in iatrogenic problems that had to be taken care of in addition to our treatment of their dysfunctional scapular mechanics. So just the way the CO balances a ball on its nose through proper mechanics of all the muscles that start from the floor up, the scapula positions the glenoid underneath the humeral head and allows the coracoacromial arch to move out of the way. And so it's not hard to understand why someone may present with instability when the scapula isn't moving appropriately. And in fact, it was Uma Srikamaran, who was at the time our fellow, who published an article in JBJS entitled Scapular Winging, the Great Masquerader of Shoulder Disorders. And you can see below how we really focused on the errors that were made. And frankly, again, years later, same problem with initial misdiagnoses and same problem with multiple procedures performed for things that weren't really the case. And if you look here, this is a pie-shaped graph that's very discouraging. All the different diagnoses that came to us where the scapula was really the fundamental problem, and then the surgical treatments which had failed before they came to us. Here's an example of a patient who was diagnosed with anterior instability and a SLAP lesion and who underwent treatment for these things. Here's a patient who had a diagnosis of a rotator cuff tear. I think you can all see the malpositioning of the scapula here. And in fact, Joaquin showed this before. It's very easy to see how the scapula is laterally displaced with this patient who has a trapezius dysfunction. What's interesting to me is way back when I was trying to treat these the way Lubiliani and colleagues described with the so-called Eden-Lang procedure, the results weren't very good. Look here at this patient pre-op on the left and post-op on the right. And if I had his face uncovered, he's trying to smile just to make me feel happy about it, but he really wasn't that great. And again, I don't think we have time for Bassam to describe his treatment of this, but he changed entirely the way we treat this with much more appropriate biomechanics. This is not a biomechanical solution to the problem. In fact, Dr. Alassane and a host of others, including former fellows, participated in this collaboration at JBJS in 2022 to talk about muscle tendon transfers around the shoulder. This is a very good article to review, mostly detailing how Dr. Alassane had changed the way we do these operations. And even beyond this, he's added to what he does with his so-called scapulopexy procedure. Speaking of the scapulopexy procedure, otherwise known as sexy pexy, he has the feeling that not everybody who has a dysfunctional serratus has a nerve problem. And this is a very important distinction because the assumption is that we did too many pec major transfers for winging. I'm not entirely sure about that, but nonetheless, this is a published new thought that may change the way we approach things. So I'm done now. I just want to point out the theme here is not to make this a tricky diagnosis. If you recognize the possibility and you look at someone who's failed some of these treatments I've shown you, you might make sure that you evaluate the scapula appropriately so that you can understand the reason for the failure may be a misdiagnosis and a mistreatment from day one. Thank you.
Thank you, Dr. Warner. Appreciate the historical perspective. I think that's a great way to look at things just from the context over time to see what we have learned over the years. The next up is going to be Bassem El Hassan. He was born in Lebanon. He received his medical degree and completed 3 years of general surgery, followed by a year of orthopedic surgery training there. Then he came to the States and did orthopedic residency at the University of Illinois in Chicago, and then did 2 fellowships, one at Harvard, one at Mayo. He has also won the Mayo Teacher of the Year award twice, and where he was on faculty from 2007 until he joined Dr. Warner as co-chief of the MGH Shoulder Service in 2020. He's published over 125 peer-reviewed articles and has authored over 30 book chapters. He's a true pioneer and has developed numerous novel surgical procedures. And this evening, he'll be talking about what is new about non-structural STAM and what to do with it.
Thank you, Brent. Thank you, Brent. And thank you, Joaquin and GP, very much. Joaquin, for your long-standing friendship that will continue, and GP for your partnership and mentorship. I just changed a bit of slide because like the anatomy and the background perspective that both speakers were fantastic and outstanding. So I'm gonna just like summarize by saying why the shoulder is so amazing. Like why are we like great shoulder? We love shoulder. It's just because it is the only girdle that has a 3 joint in one articulation, and it is so fascinating about like the level of motion that we can get from it. And then Joaquin showed this one very nicely, but I will add to it a little bit more about also mobility, because now we can see it in 4D CT scan that even the motion of the clavicle, SC joint and AC joint, they're 3-dimensional and they have a lot of rotational activity. And honestly, philosophically, if you think about it, the only reason we have this connection because we have a chest. If we are flat, we don't need this. But because we have chest, we need something to slide around it, and you have these muscles going around it. This is, for me, philosophical in terms of why this way to be able to allow us to do all these motions. And Joaquin described very, very nicely the anatomy of these muscles around the shoulder and the scapula that allow this to move very well. For the audience, please know that the scapula is the shoulder. I do not understand why we separate them. It's the same structure, but instead of looking, oh yeah, this is the shoulder, no, the scapula is a black box. They're exactly the same structure. The rotator cuff are sitting and essentially they are in the scapula. But with that, we look at the shoulder as a glenohumeral joint through the small box, and everything else is separated, which is not correct. And this is a 4D CT scan. We have been doing a lot of this right now. The main reason is like, I feel a lot of us have very good understanding about the scapulothoracic motion, but in order to explain really how it goes, when you be able to do this imaging live, you'll be able to see the mobility and how each muscle will incorporate into this motion. So when we look at all this motion that happen and everything that Joaquin talked about and GP talked about in terms of the stability of the scapula on the chest wall to be able to move, for the shoulder to move, if we think about the scapula as a boat, which is true, it's sitting on the scapula. Like if you take the clavicle out, the scapula fall down. There's nothing. So you have all this muscle on it, and the rotator cuff is in it. But if this is a boat, it's like a boat, and if it's stable, everything in it's stable. But if it's not stable, everyone's gonna fall off. This is what GP showed. They have someone you're doing instability surgery while the boat is unstable. Why are you fixing inside if the outside is not correct? And today, even we have visitor with us in the clinic. Many cases, like everyone is looking at images, and this is a diagnosis. And if you look, the patient have a scapular problem. It's the same, but nobody, like we have so much now invention and imaging that we forgot the basic, just like a very simple examination. Now, again, abnormality of anything around the scapula, bone, that JP talked about as well as Joaquin, can lead to abnormality. So if you look at this one, I'm not going to tell you what's the diagnosis, but this is definitely the scapula is abnormal. So if I ask any of you, is this scapula winging or this is dyskinesia? And this is where I'm going to talk about like the next term. It always confused me when we try to differentiate. If someone called me, say, this is dyskinesia, not winging. What does it mean? Where is the line in between the two? So because of this confusion between the two, we said we have to replace it. And we came with the term STAM, scapulothoracic abnormal motion. It is very simple. It's the English version of dyskinesia. and it includes any abnormality. This is why right now in our clinic, my fellow, they're not allowed to say this canis are winging. They say they have stem and show me what's going on. And this is this is like how stem is spreading. This is in Val d'Isere. This is in Spain. Everyone now, when they see stem, they're sending me video. They're talking about stem. So, and this is again, I mentioned to my fellow today, when the patient come with the scapular problem as the main reason, not pain. The main reason is I have problem with my scapula in terms of motion. It can be divided into two broad categories: functional and structural, or what we call it non-structural or structural. Now, in order to differentiate the two, like what are you talking about here? We are not used to the non-structural. As shoulder surgeon, as orthopedic surgeon, we're orthopedic surgeon. We want to see fracture, tendon injury, nerve injury, dislocation. What does this mean? What's functional mean? And this is a video I've showed in the prior meeting. I asked my fellow, what do you think? Is this normal? I told them, like, check this one. Yeah, maybe a little bit of stem. No. Yeah, normal. I told her, okay, let's wait a little bit. The same patient. Is this normal? This is scapula winging. This is dyskinesia. This is stem. What's this? So and this is where you have to be very careful when you talk about like what's normal, what's abnormal. So when all the shoulder muscles individually are normal, but together are abnormal, this is where we have the abnormality or the non-structural stem. Usually the culprit is pec minor, but there are a lot of muscle abnormal around the scapula to cause this. Like this patient, the left shoulder is normal, scapula is normal, the right is not. But serratus is normal, trapezius is normal, every single muscle is normal, but together they're misbehaving and they're causing functional stem. Now, this is a question that I get asked all the time. Why? Like, if there's nothing structurally abnormal, why this is happening? Honestly, I think the main reason it's happening because we're human. Because if you look at the complexity of the trunk of the elephant and you try to compare it to the human scapula, I did not know that the trunk of the elephant has 40,000 muscles. But you never see the trunk of the elephant going into crazy. It's all under control. But a human body that has 650 muscles and only 14 muscles around the scapulothoracic and the shoulder, you can see all this abnormality. So why the trunk of the elephant with 40,000 muscle you don't see any time very functional abnormality, while in the human you see it. And this is what we are working on to try to understand how the normal connection between the brain and the body, like the skeletal muscles, can be affected to cause this non-structural stem. And now with this one, so when we talk about functional stem, no serratus paralysis, no trapezius paralysis, no shorter clavicle, no deficiency of the scapula, what are the type of functional stem? We have 4 types. Type 1 is essentially what we call pec minor syndrome. Type 1, they have minimal stem, but most of their symptom is tenderness over the pec minor with positive TNL sometime. It's called type 1. Type 2 is the most confusing for most people because it's very, very similar to serratus anterior paralysis. You have 2A and you have 2B. With the 2A, like JP showed some of these and Joaquin showed of these, the pec minor hyperactivity, upper trapezius and rhomboid are hyperactive. The serratus is hypoactive, but not paralyzed. They can have recurrent instability. I have so many patients coming with these, and they have multiple surgeries, like JP showed. In general, they are easily reducible when you try to reduce them, which mimic very, very much the serratus paralysis. And 2B, also they come with stem, very limited motion, but it's very hard to reduce them. Sometimes you can, but most of the time you cannot. I try to push very hard. So in general, the red flag, and I told my team this way, except if you have bony structural abnormality, like the Joaquin showed the case, where you cannot reduce the scapula on the chest wall, then if you cannot push the scapula on the chest and the patient is fighting you, this is red flag. So like this patient, look at the shoulder right now. He's going to subluxate. So this is stem, and I told her try, and you're going to see, boom. We see a lot of these. Now, some surgeons suggested to do like labral repair, whatever, what JP showed. Now, let's look at this. I'm trying to reduce. The scapula loves to be on the chest. The scapula does not like to be away from the chest. And when the patient fights you, this is red flag. as long as there's nothing like in the bone that inhibits you from doing this. And when I'm doing this one, she could not dislocate her shoulder anymore. So this will be someone with a big mistake to try to do something on the shoulder itself. 3 and 4, you rarely see them except if you have very busy practice in scapula. This one, they look like sprangle, they look like dystonia. Everything is contracting, you cannot reduce them, they're stuck. You think there's a bony abnormality, you think you have malunion, you have something wrong, but in reality, the muscles are okay. How would you know? Like these are patients, you cannot reduce them, the same thing. And then under anesthesia or even sedation, everything is moving very supple, as if there's nothing going on. This is how you know it is co-contraction of the muscles. This patient has very major stem with subluxation of the shoulder. I could not reduce her shoulder whatsoever. Under anesthesia, it's supple, there's nothing. So there's no bony abnormality, there's nothing abnormal, it is just the muscle that they activate. 4, I love dancing, but whenever it's pathologic, this will become abnormal. And 4A is whenever it's induced by the motion, and you see the scapula is wiggling all the way. And 4B is very rare, but it happened, this is ongoing, they don't stop. It's almost like seizure activity. So, and you can see this one, like they're ongoing, non-stop activity. So by physical exam, and I don't have too much time, but I'm gonna go through it quickly. When you examine this one, the wall push-up test, we stopped it. Every one of these is a STAM 2A or 2B, which means functional STAM. And all of them, they have positive wall push-up test. So let's overthink this one then. Because when you look at the serratus paralysis and you look how the scapula is sticking out, it's very similar to STAM 2A and 2B. And like this is one, like they look very similar. How are we going to differentiate them? Like this is a patient I've seen overseas. The trapezius look normal, but you can look at them, they look like a serratus paralysis. So how to differentiate between the two? This is the test that we came up with, and I published along with my junior partner, Ryan Lohr, which is the flexion resistant test. And in this one, if this one is positive, it means like if you have the scapula wing of the chest with the resistance above 100 degrees, 100% the serratus is abnormal. So this patient is a STAM 2A. At 30 degrees is winging out, but when I go 100 degrees, wing. Now he's not, remember, I'm saying winging, it means physical examination is winging off the chest, and this is negative. So anyway, while in serratus paralysis, anytime you do this test is positive. So this is for us is more important than EMG. But what Joaquin talked about the EMG as medico-legal test to make sure like you have your documentation, I think this is important. The other test that we do very often in patients who cannot do deflection, if let's say they have paralysis, is protraction against resistance, or Joaquin test, which is the same as like very similar to the boxing. And if this one, they wing off the chest wall, it means the serratus is abnormal. It is not abnormal in functional abnormality. So right now, I'm gonna just bypass this because I don't have more time. But let's say, I'll give you a very quick example. Like this patient, he came, they sent to me for pec transfer for quote unquote serratus paralysis. Look at the right side. It is very tricky, right? Now, I'm gonna try to stabilize the scapula to bring the scapula where it's supposed to be. He's fighting me. That's a red flag. Then I did for him the protraction against resistance. It was normal. It means the serratus is normal and this is functional abnormality. So how to take care of these? These, they do not need muscle transfer. This is like now, the way we deal with them is we think it's function coming from the brain. If we can hold the scapula in a position to let the brain activate the muscle appropriately and they go back to normal, this will be able to go. So what we do, pec minor is culprit, we release it. And if we tie the scapula with a tendon, not a suture, on one of the rib, it will hold the scapula in this stable position and most likely get this muscle to reactivate correctly. We call sexy pexy that JP talked about. With type 1, the pec minor syndrome, only pec minor release. But with the type 2A and most of the type 2B, we do what we call sexy pexy. Sexy pexy is pectoralis minor release. We do it arthroscopic. And we release, a lot of you know how to do this one, but like when we do it in the lateral position. And if brachial plexus need to be released, we can release them at the same time. And the sexy pexy, this is what the pexy is, essentially tying the scapula on one of the rib, only one with a tendon allograft. The purpose of the allograft to stretch over time, but because now the brain looking at the scapula sitting in the right position, it reactivates the right muscles around it. So essentially, this is a serratus. I always take a video to show to the patient that's normal. And then we expose the distal scapula and we create a hole in it. And then we're going to pass a tendon through it, around the rib, and tie it. And this way, when the patient tries to move, they try to do this very abnormal motion unintentionally, they cannot do it. They start to activate the right muscles. And over time, this tendon will stretch over time. So this is the rib. We're passing suture around it. And we do a lot of this in the surgery center, by the way, because this is one level rib. There's no big deal if you're comfortable around the ribs. And then you pass the suture inside the distal scapula, and then you pass the tendon around it. So now you have the suture around the rib inside the scapula. You have one of the team preparing it. Usually I used to be posterior allograft. And then you pass it through the scapula around the rib to tie it very nicely. And this is how it usually goes. And this is what this sexy pexy is: pectoralis spine release and scapula pexy. In fact, the patients know right now I have my sexy pexy. They call it sexy pexy. So what about the outcome? The patient I showed you that needed the pec, this is a patient I showed you with a major stem. Look at him. This is sexy pexy. Look at this motion. He did not need cerebral ST fusion. He did not need a pec major transfer. And you can see right now his SFRT, shoulder flexion resistance test, is negative. So again, you get the right diagnosis, you get the right treatment, they do great. And we have a lot of example about this one. And you can see this outcome. And we publish about them. GP showed you this one. For the more stubborn one, which is type 3, 4A, and 4B, usually we do right to left scapular tethering. So essentially, we use a Achilles tendon allograft, and we connect the graft from side to side, and we hook the scapula together. And this is a patient I showed you before with like almost dystonia. And you can see her only 4 months after surgery. This is another patient around 6 months after surgery, and you can see their motion. So in summary, understanding the anatomy and functional biomechanics of the bones and muscle around the scapulothoracic articulation are essential to manage the different pathologies around the scapulothoracic articulation. And if you want to learn more, you can join me, Joaquin, and JP for our shoulder tendon transfer course in scapula course with the AO on November 14, 16 here in Boston. Thank you very much.
Outstanding, Boston. Thank you so much. We do have a few minutes before we were going to come up to the top of the hour. I do not see any questions in the chat. Maybe I've missed something. Feel free to ask any questions of the audience live. At the same time, let me start things out. Boston, with the 4 stamps, what would you say the ratios are for each of those in your experience?
The most common that I see, well, it depends on the practice. The most common I see in my practice is a stem 2A, followed by 2B, followed by type 1.
And would you say that's the same for sports doctors, like a general orthopedic practice? That's the most common that they're also going to see, or is it simply because your practice is so subspecialized?
I think sometimes these are missed a lot. And I'm really hoping from this overview that we are giving here that people will start to look more into the scapula, into every single patient to see them. But yes, I do believe so. Specifically, I would say, please, specifically, patient who is 12 years old or 13 years old with no trauma, they cannot have labral tear for no trauma. Look at the scapula, because I have many of these patients coming so young, having labral repair or capsular shift, and there's the problem with the scapula. So yes, young female, young age, look at the scapula. Usually it's type 2A, and you leave them longer, they end up in 2B, which is more stubborn type.
That's good. Well, talk a little bit about, maybe we have the panel discuss the learning curve with taking somebody who's intimidated by the scapula, really does not look at a patient without, does not undress them, and then just look straight to the MRI report. Talk to us a little bit about the learning curve of what you would encourage step by step, how you get more and more comfortable with demystifying the scapula.
Joaquin, go ahead.
Yeah, I can go first. I think, if you've never had the chance to be trained by someone, I think it's useful to visit a person. That's very powerful. And I think if you were to spend 1 or 2 days with Dr. Warner or Dr. El Hassan, that will really open up your eyes about how much you can gather from your physical examination. Of course, courses that are being put, like the one we're doing in Boston, I think are very helpful too. But the key is that it doesn't take that long to assess the scapula. The key, like Dr. Warner said, is make sure the patient doesn't have the shirt on and look at them from the back. And you can do 6 to 7 maneuvers very quickly. and it's not that difficult, So I think that's the way to address that. I do have a question for Dr. Hassan, if I may, Brent, is that okay?
Oh, absolutely.
So, Bassem, for the patients that have a non-structural stem, let's say the patient that mimics the serratus, how long do you try therapy before you say you're not responding, you need a scapulopexy procedure? And have you found any specific therapy that actually works? Because that's what I'm struggling with right now is how long do I wait? And oftentimes I say, well, you have to do therapy. And it's like, well, what therapy? I have tried therapy and nothing works. Have you found any insight about what exercises work? And do you wait 3 months, 6 months, a year? Tell me about that a little bit.
No, this is a fantastic question, Joaquin, because honestly, I know we are not a neurophysiologist or a neurologist. However, it's truly about how long does it take for the brain to change, to become stuck. What I mean is when you talk about, let's say, meditation, mindfulness, they tell you in a lot of study, 2 to 4 weeks, the amygdala lit up, it changes. And this is a study I'm trying to do. So it can change very quick. And the longer you wait, it becomes so hard to reverse. So there are 2 main factors: timing, when the patient present, and the type of stem. When I noticed some patients progress from stem 1 to 2A to 2B. So it's very interesting. I did not expect that at all. I did not do the classification based on this, but I noticed they can progress from one stem to other, number 1. So if they are stem, let's say 1, it's simpler. 2A, it's also okay. 2B is really tough, and 3 and 4, they are much harder. So for me, when they present with a stem, usually they are always late. They're never coming within 1 week, 2 weeks. And you explain this for you at Mayo, usually months, sometimes year. If they are type 3 or 4, this one, you can try shoulder pacemaker, like the machine that you put around, as you know, but I'm trying to explain for the rest, does not work. Botox, what are you Botoxing? If someone doing this, what are you Botoxing? It's not going to work. For the type 1, Botox is worth it, but they end up needing Beckmanner syndrome, release. The 2A and 2B, I always, no matter how long they have been, I try to explain to them everything, but I tell them, this has been going for a while, it's harder to reverse, but we can try. Let's do Botox at the pectoralis minor and try the shoulder pacemaker at the same time. Maybe you have a chance in this. Not a single one, it worked, no matter what the time. If the time was 6 months, 1 year, or 4 years, they all failed it. I'm sorry to say that.
No, yeah, it's important to know.
Yeah.
There are 2 questions that are out there. The first question was in talking about how you can have different etiologies causing STAM. The question is scapular fracture malunions or non-unions. Is there a specific type of scapular fracture pattern that will have a higher predilection for STAM?
Yes.
I can go ahead, Joaquin.
I'll just say a few words and then you can connect. So I think it's uncommon. I think in my practice I have done 4 scapular body osteotomies, so very uncommon in 20 years. And the ones I have seen are the ones that have an angulation of the scapular body. Those are the ones that typically patients feel like every time they move, the scapula rubs with the chest. And if you do an osteotomy, then they get better. But it's very rare because the scapula is so cushioned that most patients can tolerate substantial malunion. Bassem, what are your thoughts?
So when I started at Mass General, I had a patient from JP sent to me. If the fracture involved, in fact, this is very interesting. If it's involved the distal scapula at the insertion of the serratus anterior, and this fracture is displaced in a way that the impact of the serratus is affected, these are the ones that can cause STEM, not the scapula body. I agree with Joaquin. Either the spine of the scapula because of the trapezius, or the distal scapula where the distal serratus, most important part of the serratus, if it displays very lateral, it can affect the mechanics of the scapula. They end up with STEM.
And I want to add in something here, just to make sure we don't miss it. I've seen a number of cases, not many, but a number with osteochondroma of the scapula that present with catching and STAM and, you might call it prosectomy, whatever, that either I or others, first one I saw do was Rolly Jakob, a Swiss surgeon, removed. I've also seen it with rib fractures and callus from the rib fracture. And, you know, the other thing, Bassem, is, and you were my fellow and published on this, we had a number of patients with a resection of the scapula from a variety of reasons. One of the ones, the one you published with me, somebody was fixing a clavicle fracture and got into the vessel. And after 25 units of blood and an SICU admission and resection of most of the scapula, of most of the clavicle, she came with a terrible pain down her arm, with a drooping shoulder, the scapula wasn't moving, etc. And actually, you remember our solution to this was to reconstruct the scapula and fuse it so that the weight of the arm with the scapula hanging down wasn't pulling on her plexus, and her pain went away immediately. So you showed that was Joaquin alluded to that with the shortening malunion of the clavicle. It can also be iatrogenic removal of the clavicle or fracture or something like that, and they're rare, but that's out there as well.
I want to go to a real quick question before we have to leave because of time. The question comes in is, please suggest a single best imaging modality to rule out shoulder elevation abnormalities.
Rule out what?
Shoulder elevation abnormalities. I don't
That's
know if you can.
difficult question and I kind of understand the question. It's difficult to answer that. I think in general, any patient that has difficulty with shoulder flexion should have plain x-rays. That probably gives you the most bang for your buck. But if you need to assess the periscapular muscles, I think a chest MRI is the most useful. But I think this individual is thinking more about, you know, what is it that I cannot really avoid in any patient. I think is plain x-rays, to be honest.
Perfect. Well, with that, I think we will call it an evening. I would like to once again thank our distinguished faculty panel. And at the same time, I want to thank the audience for participating on tonight's webinar. Thanks so much, and hope we can see everybody in November in Boston. Take care.